¿Te gusta la papita, mi niño? Ya.
No, ya empecé a grabar
¿Mm?
la clase.
¿Y te está saliendo?
Sí, claro. Esto es todo lo que hablamos también, ¿sabes? Mami, mira si es mi libreta por ahí.
Hello. Hello, everyone. Hey, my chat people. Hello, hello. I'm gonna give a couple of minutes for everyone to get here. Still see that we're missing more than half. Hello, hello. We have a few people. Yeah, so half of you are still missing. So a couple of minutes and then we're gonna start like always, okay?
La niña, ¿se va a ir a la coba? Qué bonita.
Yo le acordé otro pantaloncito que es más clarito.
No, pero se te queda bonito.
Pero qué va, bonito, se quita arreglarlo, porque aquí abajo sí se le ve muy feo.
Eso está bonito.
No, porque el otro que yo me puse que es cortico, que también para arreglarlo, no se le nota tanto. Que es porque me puse él.
No, se te queda muy bien.
Pero el otro que está más, que es de color más clarito, ese sí hay que hacerle esto de
Pero se
abajo.
te queda precioso.
Hola, hola.
Hello again. Let's see, who do I have? Oh, hello. Friend, Eileen, Cristian González. Who we have on the phone?
It's Barrett.
What?
Barrett.
What's happening still?
No, I'm leaving work and I can't get in from my phone, so
Okay.
I won't know if it's messed up again until I get home.
Okay. Let me check real quick. That's a little bit better than what I thought. Okay.
Yeah, it won't let me from my phone, so I'll try when I get home.
So yeah, it's um, no, it looks like it's good so far. Okay, let me just change your name here real quick. Suitcase, right? Okay, so I'm just looking at the. Uh, what we're supposed to do today, and we have the CPT. Is the next section that we need to go over. Let me see if we can show you this. Does not open. If it doesn't open properly, we can move to the HECPIX, but I would like to do it in order. Okay. Okay, it's not letting me in. Vanessa. Hello. Okay, now it's still looking weird, but you should be able to see it properly. Can you see my screen and can you see the actual words that you see that are there? Hey, ciao people. Yes, yes, yes. Thank you. Okay, so what we're gonna talk about today is the CPT. Last time we talked about the ICD. We talked about how the International Classification of Disease is seen, how it's used. We talked about that a code can have from 3 all the way up to 7 characters. It's alphanumeric, so it's a combination of numbers and letters. Today we're going to talk about the CPT. CPT being not international, it's maintained by the American Medical Association. CPT stands for Current Procedure Terminology. So what we're going to do is get the actual procedure, whatever we're doing to the patient, and converting it into code. So it's called CPT, American Medical Association. We change it, or we do modifications to the codes every year, and it has around 10,000 codes. It's maintained and printed and done by the American Medical Association, only used in the US in combination with the ICD for reimbursement. So this works. Go to the next page. Again, current procedure terminology is the CPT. It is for the procedures and is reported into the insurance claim. It's published by the American Medical Association. This is better. There you go. Published by the American Medical Association, and I will give all the codes for procedures performed and services provided to patients. We have a few different levels, so we're going to talk about them. Level 1, Health Common Procedure Coding System, or HCPCS, and also we have level 2, and we're going to talk about level 2 on the next chapter. So tomorrow we're going to talk about HCPCS level 2. So as a rule of thumb, all of them are HCPCS. All of them are Healthcare Common Procedure Coding System. One, we call it the CPT, because it's the services and provider and services provided by providers, or procedures provided by procedures. That came out wrong. Procedures provided by providers. There you go. Rendered by provider. That's the word that I'm looking for. And those are going to be what we call CPTs, but all of them are CPTs. So HCPCS are the most used, or the way that we say when we talk about HCPCS level 2. So the organization of the CPT, we have little things that we see. I like it. Current procedure terminology is published again. They are going to be in a 5-digit numeric code. Okay, they are going to be description for procedures and services. Example, our favorite code, 99203. So here you go, 99203. Some of them you can the code or code if you want. Uh, some you can, but at least the first few numbers you can get them. So what are we gonna do? We're gonna use this for inpatient, hospital, and for outpatient billing in coordination with the ICD in order to get it uh, to get the reimbursement or get the procedure paid. An example here it says physician provides an initial and subsequent hospital inpatient evaluation. The physician will get an ICD, CM, and a CPT code. Both of them, because it's outpatient, we're going to put them into an CMS 1500 claim, and we're going to uh, uh, charge the insurance that way. If the patient is an inpatient or is a patient that is admitted to the hospital, instead of the CMS 1500 form, we're going to use the UB04 form. We already talked about them. Now, there's a few things that you need to know, and here talks about HIPAA. For the HIPAA and HCPCS, everything that we put there, it's going to be protected. So HIPAA has to, everything has to be HIPAA compliant. Doesn't really matter what the service is. So for some specific things, we're gonna have HCPCS level 3. But again, most of them were eliminated as we started using the other ones a little bit more. So you'll see how when we go over them, you see which ones are not used anymore. So every year, the American Medical Association is going to check and give a few uh, suggestions of use, and they're gonna eliminate codes or create new codes. For that, the CMS will send the the codes every year. Okay, every year they're gonna have that new set of codes. Remember, who's gonna be informed of those changes? Providers' offices or hospitals, clinics, anyone that has that's providing a service. So because of that, anyone that is a covered entity will require to know what the codes are and what do they mean. So remember, one of the things that I always say is that the ICD, okay, that tells you what the patient has will justify the procedure. And by doing that, we're saying that the procedure by itself cannot be billed. You cannot charge a procedure or money for a procedure that it does not have an ICD, and they have to match. Really, really important. Now, many of the codes we're gonna see will require modifiers or things that are gonna change the price of it, but some are specifically what the code is, and there's nothing to change. So if you have to change something, it will probably be the modifier. Also, they have units, and this is an important one, relative value units. So whenever you're doing Medicare, Medicaid services, or CMS, they're gonna say that each one has a service. So what is it that they're actually paying for? So the value has to do, or the best way I can describe that has to do with time. So how much time the physician is gonna spend with the patient. That doesn't mean that if the physician is super slow and they take their time, that visit is gonna be more expensive, or if they do it really fast, even though if it's difficult, the visit will pay less. It means that it depends on what it is. It has a value already set in. So the time the doctor's gonna see the patient, to ask all the questions, to get all the information, and then how complicated it is. It's taken into account, and of course you already know it's put in the physician fee schedule tools, and we saw that last time, and we saw that we can change or we could pay more or less. It depends on the area that you are. So all those things are taken into account when we're talking about CPTs and the price for them. Now, this is the meat and potatoes here. We have category 1 codes, category 2 codes, and category 3 codes. So again, for all the information that we're gonna do, all the things that we're gonna get, these are the two main ones that we're gonna use: category 1 codes and category 2. Category 1 means that it's going to be a service or a procedure that has description and it has uh, a price tag attached to it. Okay, they are going to be 5 characters or 5 digits long. So 1, 2, 3, 4, 5, and they're gonna start depending on each chapter. So you already know that 99. Okay, 99s are gonna be evaluation and management codes. So again, evaluation and management, E&M codes. We're gonna see them little by little. After the evaluation and management, we start with 0 zeros. So the one that starts with 0 0 is the next one. After that, we're gonna go with 1 0, and we're gonna move down the line that way. So those are the most important ones. That's the biggest section of the CPT or the category 1s or HICPICs. And they're divided into 6 sections. You'll see they are gonna be divided by anatomic, procedural, condition, or anything like that. Now, everything else, it's gonna be alphanumeric. So category 2, codes, and 3 are gonna be alphanumeric. Alphanumeric means that it's a combination of letters and numbers. Okay. So the last one, so 1, 2, 3, 4, 5, that last digit is going to be what we call alpha. So it's going to be a letter. The first 4 are going to be uh, numbers. Now, category 2 is for things that are not uh, uh, procedures or conditions. There's basically it's used for some other things, and then it's optional for Medicare, for example. Now, the last one, category 3, is for emerging technology. So let's say that we have something that it's coming up in the middle of the year. We're not going to wait until next year in order to do it or to bill for it. So it kind of works also to follow what's happening. If you can follow what's happening, you can learn from it. If you do not follow it, then you will probably either lose it or not use it properly. So that's kind of the principle. That's kind of the way that we're doing those codes. The codes that we are going to use are going to be divided into these 6 categories here. So we have evaluation and management. If you see the evaluation and management codes, all of them start with 99. Okay, so they go from 99,202 all the way to 99,499. Now, I said all of the evaluation and management codes, all of them start with a 99. But there's some 99 codes that are not evaluation and management. So most of the time, if you see a 99 code, you should think evaluation management. And what is evaluation management? We're gonna go over it in a little bit. But evaluation management is when you go to a doctor's office, for example, when you go to the ER, when you go to the hospital. Someone has to do an evaluation on you, have to check what's happening to you, and then decide how to manage it, what medications to give you, what surgery to do, and we call those E&Ms or evaluation and management codes. After that, we have anesthesia. Anesthesia starts with 00. It goes from 00, 100 all the way to 01, 999, and then it has a few codes here, around 40 codes if you look, from 99100 to 99140. So 40 codes that have 99. Next, we have the biggest section of the CPTs. It's the surgery. Surgery is from 10,004 all the way to almost 70,000. That's where the majority of the codes are. Those are anything that has to do with surgery, and it will be divided by anatomical region. We'll see in a little bit. Radiology, 70 to 79999. Again, anything that has to do with radiology, imaging, anything like that. Pathology and lab, we have in the 80s, so 80 CO47 all the way to 89398. So if you see, there's a lot of numbers missing. For example, after this, we don't have the next number. It's again to have room for improvement. Any number that is not there, we can use it at a later date. And then you see a few of the level 2 here, because and you know that they are because they end with a letter. The last one, we call them medicine codes. They're gonna be in the 90s all the way into 99s, and they have a few stints in 99. And then we also see some alphanumerics at the end. Now, to keep it super simple, either you know what you're looking for and you go to one of the sections, or you look in the index and again to go to the section. What is the easiest way to know what you're supposed to look? If it's an evaluation management, if it's a doctor looking at patient information and deciding what to do with them, that is going to be evaluation management. That will be the 99th. If it's a surgery, it's going to be right here. If surgery won't require anesthesia, so whenever you have a surgery, you should have an anesthesia also. And then radiology, pathology, and lab is for exams that we're doing on the patient, imaging or anything else. Medicine is more things that we're doing, for example, vaccinations, injections, different medications. That's medicine. Wrapping up an ankle, that is medicine. You think about it, there's nothing here that is not gonna be covered in a procedure done by a doctor, for example. If we're talking about ambulance ride or anything like that, then that was gonna be all the way in the level 2. Then so again, there's some codes that are gonna be what we call a standalone code, or just a code. In this case, it's a 27870, and because it's a 27, you might think, okay, so it's not a 99, it's not a 0, it's between the 10,000s and the 70,000s, so that should be Jesus Christ, surgery because of a fracture. And then if you look, here's the more of description. So close treatment of a proximal fibula chaff fracture without manipulation. With manipulation, then it's a different one. So this is how simple it is to go from one code to the next one. The more information you have, the better. So again, some codes are supposed to be what we call a standalone code, or a code that has all the information in it. Some of them you're gonna have 2 different codes to see which one is more precise. In this case, with or without it will make it more precise, and that's the one that you're gonna select. Now, where are you gonna get the information? The appendices. The appendices is the best way of getting the information. It will tell you what modifiers we have. It will tell you what how to use them. So when you get those books, you'll see that we have list of things that you need to know, and those things are gonna show you where they are. I don't want to go here. I want to go here first. And here we go. There's a lot of them, and all of them are gonna tell you something specific. So in this case, we have the appendix A, or the A appendix. It has all the description for the CPT modifiers. We're gonna talk about modifiers in a little bit, what they are, how they change the pricing on a code based on if you have it or not. B appendix, it's the changes. So for whatever reason in the exams, they like to ask you how many codes change this year. So you have to go to the appendix B, and it will tell you which ones were added, which ones were deleted, and which ones were revised. C, or appendix C, is for clinical examples for evaluation and management. It's really, really important that you know, if you're working at a doctor's office or someone that is starting, that you know what are the examples for evaluation and management to see which ones are going to apply to what you're doing. Uh, we have something that's called add-on codes, or CPT add-on codes. They're going to have a plus, uh, like this little thing here. So it's gonna be what? Alright. So this little circle here is pointing at a little tiny cross. That cross is a plus sign. It's an add-on code. So that means that you have to use another code together with that one. You can never use that one by itself. So if it's a primary code, you have it, and then the add-on code will be an extra one. We're gonna go over that. Modifiers. Modifier 51 is an example of a tricky one. Modifier 61 is or 51. It's might say something like this. So codes have the no symbol. It means that you cannot use modifier 51. We're gonna see what they are in a little bit. Same thing for 63. Maybe you have it, maybe you don't. So do not report modifier 65. I mean 51 or 63 if you have those things saying no. Then appendix G, summary of CPT codes that have moderate consciousness or sedation. They were removed. That was a good thing. It made the anesthesia really hard to code because of that. Appendix H is the list of CPT category 2 or HCPCS 2 in uh, in an alphabetical clinical topic was removed for CPT. Again, it created a problem trying to do those, so that's a good thing for you guys. It will be there, but it's telling you why it's not there. I kind of the same thing. Now, J is a summary of electro diagnosis medicine listing, sensory, motor, and mixed nerves. Those are going to stay. We're going to use them for specific parts if they're going to be in medicine. K, it's things that are pending FDA approval. So they're gonna have a little lightning bolt here, tiny lightning bolt. That's the symbol that you're gonna use. Again, not that you need to know which ones they are, but if you know that you see uh, the the actual lightning bolt there, that will mean that that is pending FDA. In the exam, they might just show you that lightning bolt will expect that you know what it is. So lightning bolt, it's for FDA. The plus is for add-on codes. The no that you cannot use a modifier. Um, L, vascular family, to assist in first, second, third, and beyond third order branch of arteries. So these are gonna be modifiers that are gonna be specific to a part of the heart. They're gonna have two letters instead of, they're gonna be alpha. They're not gonna be numerics. We're gonna see them also. Appendix M is a crosswalk between CPT codes from one year to another one. We do not use that. We just started deleting them. Before, if a code was deleted, then we'll just delete the information and keep the number. Uh, Now we're just eliminating the whole thing. Summary of list of requested CPT codes, appendix N. So if you, this is more when you're actually working, you'll see that there's some codes that you might be able to use. They're gonna be in that appendix. Hopefully by the next year they will be used again because they're resequenced. So you have to get the number put back in the list. So you might use you might be using a number now or a code now that next year you won't be able to. O for administrative codes that have to do with the MAA. It's a algorithmic analysis. So again, in order to understand how molecular pathways work, then we're gonna have codes for that. P for synchronous telemedicine. Again, this is a big thing since the pandemic. So before we did not have the so much of those telemedicine. Uh, why this looks so weird? Yeah. We did not have a lot of telemedicine, and now in order to say that it's audio and video, it requires the start. So you will need to have modifier 95 to bill for a telemedicine or a teleconference with your doctor, and you'll have star sign next to the code. Because things change a little bit, COVID is already in the books uh, as acute respiratory syndrome. Anything that had to do with COVID-19 vaccine associated vaccine product or immunization, they're going to be in Appendix Q. Eventually, they will go away or at least transition into the actual code without being specific. But as of right now, they're still in Appendix Q. Appendix R is the table of digital medicine services and clinician to patient services in clinician to clinician services. So if you're doing any type of charges for digital medicine, then it will be Appendix R. S will be for AI, kind of the same thing, but now we're gonna be with the use of AI. And then Appendix T is for synchronous, means at the same time, real-time interactive audio only telemedicine. So if it's only audio, like a phone call, will be under Appendix T. And then we just saw the ones that had the star, Appendix P, for the ones that have audio and video. And again, it gets a little bit simple when you start understanding and knowing what you're looking at. Some examples with the symbols. So again, bullets. The bullet means that it's that little circle. Or the little dot is full. It's always a new code. So whenever you see a symbol like that, is a code, a new code. Let me see if I can see another one that I can compare it to. And it's not. Sometimes you have one that it's like a little O, but in that case, a bullet, it means that it's a new code. So if you have the code with a bullet there, it says code was added to CPT at the 2023. So in the 2023 year, we added the code 15853. Already you know that that's in the 15, so it's not in the zeros, it's not in the 99, so that should be surgery. And then, of course, you read it and it says removal of sutures or staples don't require anesthesia. List separately in addition to evaluation and management code. So you have an evaluation and management code, add on this new code 15853. Triangle is a symbol located at the left of the code. Again, and identified description was revised. So the number didn't change. This description of it did. So again, if there's a code that you use a lot, at least once a year when you get this, you should check, hey, I use this code. It has a triangle there. Let me see if the revision or the information that it says now still applies, or do I have to change that code? And that's kind of how you go about it. So again, the triangle, the description was the thing that changed. And now two horizontal triangles, symbols. The inside of it, you will see that it's the whole thing, okay? Means that all of it was either changed, it was deleted, or it was a new edition of it. So all of those codes, and it means like all the codes from this code to this code has been deleted. So 80, 50, 00, 50, or 500, and 80, 501, 80, 502, all of them were deleted. And then if you want to use any of those codes, you need to go to 80, 502, 503, 504, 505, or 506. But we're saying that not only one code was changed, it completely deleted. So what happened to it? It's gonna be in between that little symbol. Oh, semicolon here, super tiny, just in case, you know, I don't know if you can see it. Okay. Semicolon. It's the descriptions are not printed in the entirely, so something it's missing. So what they're gonna do is just go back to the common portion of the code and get it from before. So, for example, these two codes, if you see, this code has the first part of the description, and then this last section here is the one that changes. So after the semicolon, that changes. So this one won't have the whole description. You have to go to the one before it. So scleral reinforcement without graph, 67250, with graph 255. So again, you see that little section there, the semicolon there, that's where things are going to change from there on. And then you have 2, 3 options with, without, and then you decide which one it is based on the description that is giving you the medical record. The plus sign or the symbol for add on. So the plus symbol as per a CPT code means that the procedure have to be either performed at the same time or with something else. So it always has what we call a primary procedure. So this is the primary procedure. Okay. Osteotomy of the spine, posterior and posterolateral approach, one vertebral segment in the cervical. Again, you see the semicolon here? I can say it could be cervical, it could be lumbar, it could be anything else. In this case, it's cervical. Then, so that code is the original, the principal one. Then, for each additional vertebrae or vertebral segment listed separately, we have to put an add-on code. You do not put that 22, 210 twice. You have to put that one first and then the 22216 as an extra code. So we're putting them together. Instead of saying I did this thing twice, I did it once plus this other one. Now, you might think, well, it's easier to put the other or the code twice. Maybe the code like this one might include some other things, and then by doing the add-on code, it's gonna be paid accordingly. If you put it twice, what they're gonna do is they're gonna deny both of them because they might think that you're doing it wrong, or they might say different procedure, and for sure you cannot do the same procedure in the same place twice. So it requires an add-on code. Again, the forbidden symbol means that it's not used with modifier 51. And again, it's and or codes. You cannot use add-on codes with modifier 51. Simple. You'll see why in a little bit. The flash or the lightning bolt symbol indicates that the procedure, like we said, is pending FDA approval. So we're not gonna wait until next year or whenever it is that FDA gives the approval. If you're using it right now as part of a clinical trial or whatever it is, it's gonna have it there. So every year you're gonna see a few of them of new things coming better. Things are happening all the time, so we're trying to make sure that we can code for them. And again, not only code and bill for them. The number symbol, it's gonna be for resequence, so the number has changed. So this number has changed. So you need to know that for this description, this is a new number. Here, this is the one that I was kind of looking for. So when you see a bullet, it's a full circle that has a specific color. That's the one that we said at the beginning. It's a new code. When has a little arrow in the inside and it's blue, it is for that the code or has changes, so you have to go to the publication. Green means that you have to go to the CPT assistant, monthly newsletter because it changes faster. And then red, it says that you should go to the clinical examples in radiology. So it depends on who it's actually using it. It will have specific ones. So again, most of the red ones are gonna be in the 70,000s because it's radiologic. But then in the inside of it, they'll have changes and when those changes were. So again, the important part is when you can use them and when you can't. Start is for codes that can be reported in telemedicine services with a specific modifier. This is how it looks. Let's see if you can see it here. This is how a code. This is how when I say code and modifier together, that's a CPT code. The first 5 numbers, space, and the last 2 numbers are gonna be the modifier. So that's what we're looking for when we say modifier. The speaker symbol is used for audio only telemedicine. Remember the flash or lightning bolt is for both with audio and video telemedicine. Inverted parenthesis symbol identifies duplicate PLA analysis test. So again, you'll see what they are in a little bit. Double arrows up and down identifies that it's a category 1. So those are the ones that have to do with pathology and lab section. So they are not going to be completely category 1. So that's why they're separated into the category 2. So usually you should know which ones they are in order to apply them properly. We already saw a little bit of this when we saw the ICD-10. When you're gonna get anything, you have to go to the section, subsection, categories, and subcategories. The way it works is you're gonna have something like this. This is the section. Section is surgery. The subsection will be the integumentary system, skin, for example. Category on the system will be skin, subcutaneous tissue, and accessory. Subcategory is what are we gonna do? In this case, it's an incision and drainage, and then the code, and then the description. So kind of the same way that we did last time, we have to go through different sections. Now, it is a little bit easier because it's less codes. It is a little bit easier because all the codes are gonna be in grouped by either the section or the subsection. In this case, surgery, that is the biggest one, has the system. So if you understand a little bit of the systems on the body, you should be fine. And then just know what the different symbols are. Plus, in this case, is the add-on code. The no here, or the symbol of no, is for non modifier 51. Simple if you understand, because all of those symbols can apply to all of the codes. Now, surgery gets a little bit more complicated because surgery is usually considered a global procedure or a complete procedure. That means that when you talk about surgery, you're talking about pre-op, surgery, and post-op. Okay, so many surgeries include the post-op and the surgery. Many of them include all of three: pre-op, post-op, and the actual surgery. So you have to go through the guidelines and say, no, which ones you can do a visit, evaluation and management, like a 99 code first, then the surgery, and then another 99 afterwards. Or can you only do one that includes the whole thing? When can you go for more than one procedure? So for example, if you have surgery of the hand, did you do surgery in both? It can happen. How would you report it, and what things do you have to put in order to get it paid, so they don't see it as a mistake? There's some unlisted procedures or unlisted services that are gonna be performed, but there's no CPT code for them. So you will probably never see that, but there's a special report for it. People that are doing new things usually when they're working at places that are doing a lot of research, they will use those. Now, what you're gonna know the way that you're gonna use this is you're gonna have uh, instructional notes. Instructional notes are the things that are gonna come when you're looking at the book, and it will say the system, this cardiovascular system, and it will tell you how things are, and then few other things on how it works, a few examples, and then it will tell you what code it is. So when you're looking at the book, what you're trying to do is matching that whole statement to whatever the patient uh, had. And again, who's gonna give you that? The doctor's gonna give you that. The computer's gonna give you that. So it doesn't mean that you need to memorize anything, but you need to at least know where to get it. So when you get something like this, 33 to 20, like I said, always go to the one that is before it and the one that is after, just like in the ICD, to make sure that there's nothing more specific before or after. Usually, uh, what happens in after is that you pass, you've done more than what was done, and before it has nothing to do with what you were doing. So that's kind of how you ensure that you are in the right actual number. Now we have descriptive qualifiers. These are terms we're gonna use to clarify the information. So again, you go to the code, and then you're gonna make sure that whatever it's there, whatever examples are there, include what you said. Because in this case, it says destruction of a lesion or destruction of pre-malignant lesion, first lesion. But it has to be through any of those means. So if you have laser, electrosurgery, cryosurgery, whatever it is, and it's a destruction of a pre-malignant lesion, and it's the first one, then perfect. But if it's not there, so that's why the descriptive qualifiers are really important. You need to read them. You need to make sure that they are there in order to use them. And then if you use that one and you do it twice, well, before you do this code again, look, there's an add-on code that you can put, and that means that you did that code first, you did it twice, okay, or 3 times, or 4 times, or whatever times it is, because you're gonna add one for each one that you do. So you're not gonna put the 17,000 code 3 4 times. You're gonna put one time that one, and then as many as you need, you're gonna put this one. And again, this is something that it's there. It will say it right there, so you have to get that information, and all this information will be translated to the computer, and the computer will show you as soon as you put one of the codes, it will tell you, hey, this could be an option. Again, as simple as this, and I think we mentioned this um, last time. If you were taking a medication or anything, why are you taking the medication? You're taking the medication and you took too much of it. Was it intentional? Was it by accident? Someone was forcing you to? Whatever it is. So kind of the same thing has to match to whatever you're doing. In this case, it says foreign body implant definition. So if it was a foreign body or something that is putting as an implant completely on purpose and nothing, you know, uh, including piercings are considered foreign objects or are intentional. Perfect. But what if it's not? The object was unintentionally placed. Ingestion, trauma, you have a knife, blade stuck to someone's body still. That's a foreign body. And it's, again, trauma. It's not on purpose. So including, so the CPT is specific, but it has to match the specificity of the ICD also. This is the example. This is for the book. I'm not gonna go over it because it's part of what you have to do for um, homework. So I'll give you the answers yet. So when you go through the alphabetical section, also like before, it's simple. You go to the through uh, to the alphabet, and then you find what you wanted, and then it will tell you to go somewhere else. So you said nasal polyp, and it says C, no. So you go to nose polyp, and then again, now you can find them. You're having a problem with nail. So nail, what is the most important part of the of the phrase that you're looking for? In this case, let's say it's a drainage of a nail. So I'm gonna say drainage of nail. You might go to drainage and it will say something like go to body part. So go to the body part. Nail, drainage. These are the two options. 100, 60, 161. That's it. There's two codes. So if you have a drainage of a nail, there's two options. Now you go to the book because you got this in the index. You go to that number because the number is gonna be in order. Remember. You go to that number, and then you look for that one, you look for the one before and the one after. And then you decide which one is. I know simple. Maybe it will make a little bit more sense when we start looking at the codes, but hopefully so far so good. Okay, so when we talk about main terms are gonna be the procedure. So or what we're gonna do: endoscopy, X-ray, surgery, specific surgery, whatever it is. Or it could be the anatomical site, the organ, the heart, colon, stomach, arm, brain, whatever it is. Another main term could be the abscess, whatever you have in that anatomical site, the condition, what's happening. And then some other things are going to have specific names or specific names of someone. So specific names or abbreviations, EEG, EKG, stuff like that. So the main term, you need to understand that the main term is the way that you are going to look for things. So there's 3 or 4 ways that you can check. So if we say open fracture, for example, okay, that's the condition, and then it will tell you of what anatomical area, so what's bone, and then what surgery are we gonna do to fix that. So that's kind of the 3, 4 ways that you can have to look for things in the main terms. Then what is happening to that main term? So do we have more things? Okay, so the main term usually has something else, and those things are gonna be the actual subterms. So you go like open fracture of, and then you go the femur, for example. So now you know that you have to go to the femur fracture or femur or open fracture of the femur. So that's how you're gonna kind of look for it. Now, the other thing that you should know, you should kind of memorize, is that everything is in a range. So the first 99 codes, 99, 202, all the way to 99, 499 is a range. So you need to know that the code that you're looking for, if it's an evaluation management, is going to be only, or it's going to be enclosed on those codes, that range. So they're not going to be something extra. So the range is going to look something like this: 99,202 to 99,499. So that means that the code that you're looking for has to be in between those. And you see that's a good way of narrowing down the codes. And again, but if you know what the code is about, then you should know already more or less what the actual range is. We have what is called convections. It's when the first they are printed in bold like this. Usually what they're gonna do is tell you that that's not the the correct term, and you're not gonna find it like that. So it will tell you C, whatever other code here. So arteriovenous shunt. And this is an example that you are going to find that one, but not this one. So all of this, they're gonna be in the index. When you're looking for that, it will tell you to look for this one because that's the actual name of it. You will now find a code for this, but you will find a code for this, and it's exactly the same thing. So the more you look at those things, also the better. I will suggest when you end up working at a place, if it's specific, like most of the places that you're gonna end up working at, or what I mean by that is like if you end up at a doctor's office, the doctor is going to do only that thing. Like let's say he's a cardiologist, so everything on cardiology. So go through the convections of all of those specific specialties. If you end up at a clinic, small clinic, they have a couple of specific doctors, a couple of specialties. So again, it's you don't need to know all the codes. You should know the ones that you're gonna be working with. Like that. That works. Look. Now, again, it depends on things that you're looking. My suggestion is to look for a word like this one, and then go down through all the things that might be there. So, for example, in this case, says exploration, is a surgery, exploratory surgery of the abdomen. So you go, well, you don't know how to pronounce it, you don't know how to write it, you don't know what it is. Well, go to abdomen. Go where it says abdomen. Then start going to the things that are down. One of the things is going to say exploration. And now, again, you have a range of what codes are. So an exploration of the abdomen, you're looking at 10, 11 codes out of the 10,000. So kind of simple to just get what the information is by doing that. So again, there's many codes that you have, but you should be able to find them little by little. And again, another little thing that's gonna be for your assignments. Okay, so now let's go through what we call the procedures. Since the procedure to select a code has it depends on the actual book, but it has between 6 in some books, 10 in some other. Your book has 8 steps. I think that's the best one. 8 steps on how to select the code. So the first thing that you're gonna do is read the introduction to the CPT manual. So you need to know how you're gonna do it. That's okay. You're all done. Then review the guidance at the beginning of each section. Let's say you've been working. Perfect. You know that. Review the procedure services listed in the document. Encounter form. So when you are at the office, the doctor says, hey, the code is 99203, our favorite code, right? Excellent. It's nothing for you to do? No. You still need to check. Okay, you still need to check that is what they want. Maybe it doesn't say 99203. It says all the things that they did. So you read the progress note or whatever it is, and it says that it was a doctor's office, and they checked this and this and that, or it was a surgery, and they describe the surgery. When they get a progress note, is what happened to the patient. An operative report is a description of the surgery. Lab report, pathology report. That's what you're gonna get if you work at a clinic or a hospital. So in that case, well, you need to figure out what it says and get the information only what is there. Never assume, never add things, never say, hey, normally this is what we do. No, exactly what it says. Remember, everything that is in the document or everything is documented is what happened. If you don't understand, if something is missing, you need clarification from the provider. You can always ask the provider and say, hey, what happened here, whatever it is. Then, after you know what it is, you get the information, you're like, okay, now let me go to the index and find whatever we were trying to do. So it was surgery, on the arm. What type of surgery? Well, in the document it says arthroscopy. Okay, excellent. Arthroscopy. Where? In the arm. Okay, so we have two things already. So now we're going like, okay, we can move forward. So why did we have the arthroscopy? Well, because you have, I don't know, whatever it was. Hernia repair is an example. Why are we finding there? What thing was tested? Blood or like whatever it is. If you have similar terms, what is the correct term? What the term are you gonna use? And you keep checking those things. Does it have an actual name? What? Colleagues, it could be colleagues with an E. And then abbreviation, CBC, complete block count, anything. Okay. When you get all that information from, again, the documentation, and now from the index will tell you this is what you're looking for, and it will tell you go through these numbers. Okay, these are the numbers that you're gonna check. Either in this case, it's only two numbers. It's not have a dash. If it's a dash, it's the range. It says there's two numbers, so you got to super close to two numbers. Now, when you read the descriptions, okay, with all the description, make sure that you get the right one and assign the code. Excellent. Any add-on code, any additional code, boom, you're done. No, one more thing. Check in Appendix B for modifiers. We're gonna talk about modifiers shortly. So it's not only get the right code, it's get the right code, add-ons, modifiers, or anything else that you need. So let's go over it real quick again. You start kind of in step 3. That's why some books say that it's like 6 steps. But it doesn't matter. First step, get encounter form, progress notes, operator report, get documentation of what happened. From that documentation, extract the specific. Why is this not going away? Here. The specific term, the main terms. What are the main terms? Where? What? Okay. What are we doing? Where are we doing it? What is the condition? What is the sample that we're testing? Any other synonyms? Any other name for the procedure? Abbreviations? Anything? Okay. Now go to the actual index, get the options for the codes, review what the information is, select a code, apply the code, apply add-ons or anything extra, and apply modifiers at the end. It should be straightforward. It should be as specific as possible. And one last thing is when you're putting that information in the CMS 1500 claim, the codes are going to be entered in the highest to lowest reimbursement. So the thing that pays the most is going to be first. The thing that you're charging the most with the first one. The thing that you're charging last should be the least expensive one. So another thing that happens a lot, and this is where you need to talk to whomever is doing the encounters, whomever is writing the in the medical records. Most of the words that we use are specific, okay, specific to what we're doing. So again, you need to make sure that your doctors and the people that are writing know how to write to make it easier for them and easier for you. A few examples here: placement of, insertion, implantation, insertion, resection, excision, radiograph of the chest, X-ray of the chest, okay, suture, laceration, repair of an open wound, nerve block placement or placement of nerve block, injection of nerve anesthesia. So it's complicated sometimes when you're using different you know words and they all mean the same thing. So you have to be careful with those things in order to do it. Uh, Again, this is something that when everyone has their books, we're gonna talk about this TPD codes, and you're gonna start looking for them. Now, modifiers. Modifiers are a set of codes that are gonna be 2 digits long. That they could be alphanumeric, meaning that they could be letters and numbers or letters by themselves, and it will change what the actual code is. It will give it more specificity. It will make it pay more, pay less, depends on what it is. So if I say a modifier is something that modifies payment of a code or charges on a code. So the 99203 is a specific code for that has a specific charge. But if you add 25, it will make it more, it will make it less. Uh, this this one here with PA at the end, in this case, it will change. It will be more specific to an actual part of the body, specific location in the body. Okay. Now, so it will change something. Okay. So functional modifiers or pricing modifiers are the ones that are gonna change the reimbursement decision. Okay. One of the examples is when we have assistant surgeons. So if we have 2 surgeons and both of them are doing the surgery, the payment is basically double. There's 2 surgeons doing the same thing or doing something. Okay. You can have an assistant surgeon. That one is going to be the primary surgeon, and they're going to pay one rate for that guy. And then for the assistant, that he's going to be there or she's going to be there just in case something happens, in case they have to assist or just do something, then they're gonna pay less. I could have someone for a surgical team, and again, the surgical team will pay more than an assistant surgeon. So any of all those things are gonna tell you what happened during the surgery and what changed, so we can do the price change. Example, I want to read this example because I think it makes a lot of sense. This one. Okay. This one says an assistant surgeon participated in an open treatment of an internal fixation of a right femoral fracture, proximal and neck. So the top part of the femur, in your thighs, the bone in your thighs, close to your hips, broke. That's what it says here. Femoral fracture of the proximal end or the neck. So the thing that goes into your hip broke. Okay, simple. Make it the bone that goes into your hip broke. It's an internal fixation, so it was not it was they put it in place, but it was open, so it means that it was surgery. So it was a surgery that put the femur back in place. Okay. The code is that one. The modifiers are gonna be 80 and RT. Okay. Modifier 80 means that there was an assistant surgeon. Okay. It is a functional modifier that impacts reimbursement. So that surgeon, we're not gonna pay him or her double. We're gonna pay as an assistant fee. And then RT is an informational modifier. It says that the surgery was performed in the right side. So RT in this case for right. So you have one that has to do with money and the other one has to do with anatomical location. Because this one says only surgery. So not like before, like in the ICD-10, that it was a specific code for right and left. We do not have right and left codes. So this code is specific to the surgery, not to right and left. So for that, we need a modifier that's going to tell you right or left. And many areas have that. I know the same thing. How does it look? Here we go. This is how they look. Why does that look so weird? Again, here. Can you see that? I don't think you can see it. There you go. 99, 2, 2, 3. And the modifier here. Okay, this one, 40, 7, 5, 6, 2. No modifiers. And you can put it up to 4 modifiers per code. This one here in the bottom, 4, 7, 5, 6, 2, modifier 80. Okay, assistant surgeons. Again, most of them doing surgery will require a modifier. Assistant surgeon, surgical team. For example, let's say the doctor is not going to charge for the surgery, all the things for the surgery, only for performing the service. So that has a code also. It's called professional component also. So the surgeon, the hospital is charging for the everything else, and the doctor is charging for his services. Then a professional service is gonna be paid to the doctor. The rest is gonna be paid to the hospital. Both of them need to put modifiers in their thing in order to make sure that it gets, paid properly. Now we got to evaluation and management. Now we're gonna go over. I don't know. I imagine you can see it, but now we are here in this section here. So if you look at the side, we have evaluation and management, and then we go anesthesia, surgery, radiology. So that's what we're gonna go over now. So evaluation and management and modifiers for them. Okay. So we just mentioned modifiers, now evaluation and management modifiers. So modifier 24 is for unrelated evaluation and managed services by the same physician during a post-op. So I said that most of the time surgery after post-op, you have, it's called a global procedure or a complete procedure. So you have 90 days, usually 90 days from surgery, that you can go and see that patient again. You can go see that provider again, and the patient does not have to pay anything. It's included in the payment for the surgery. Now, let's say you go to a orthopedic surgeon because you broke your arm, and they do surgery, and then before and then after the surgery, you have 90 days that you can go back and they can check your arm to see that everything is okay, and they cannot charge the insurance company again. But then 10 days later, you go back and now you have a broken leg. You will have to put, I saw this patient, okay, and now I'm charging a 99,213, for example, and I have to put modifier 24 to say that this 99,203 does not have to do with the. I'm not evaluating the surgery in the arm. Now it's something new, something different. So that's not related to the surgery. So because if you have a global procedure and then you charge a 99,213, they might say nope. They're gonna deny that. They're gonna say denied, and they will say something like below. That means that you cannot do an evaluation management on the patient for the same thing that you did surgery on. for 90 days. Some minor surgeries are 10 days, but usually it's 90 days. So if you put a modifier 24, that means, hey, I'm not looking at that thing that I did before. I'm looking at something completely new. So 1 week after surgical treatment, release from the release, and it has a level 3 evaluation that is a 99-213, and it's for the flu. So one was a shoulder problem, then the flu. So you have to do it 99, 213, and then a modifier 24. Modifier 25, it's significant, different, or separate identifiable evaluation and management service and safe physician the same day of other procedure. So if I'm doing a procedure and again, this is usually when we talk about this, we talk about physician's office. I'm checking two completely different things at the same time, the same day, and it's taking more time. So each one has one symptom, one thing. You have to make sure that you put it there. So this is kind of the example here in the bottom. Okay, annual examination. Okay, when you're doing the examination, an annual examination, you find that the patient has something else. Okay, so now annual examination, that one, and then all of a sudden a level 4 examination, the modifier 25 means, hey, I was giving the patient a routine annual examination, and then I ended up with a level 4 examination of something else. Okay, so you can charge for both of them only if you put the modifier 25 there. Modifier 57, decision for surgery. So if the surgeon is going to perform the surgery and the surgery is considered a global procedure, you could do a modifier 57, and it's called that. It means that we're doing an evaluation and management as an initial visit to see if we're gonna do surgery or not, and it will be exempt of the global surgery package. So that means that I can charge for both of them. Okay. Again, only if you put the 57. Don't put the 57, they will deny it, and they will say that it will be part of the global period at when you're doing the surgery. Here it's an interesting one: greater, reduce, or discontinue service. So you were doing a surgery, or you were doing something, and all of a sudden the patient got complicated, and we start the procedure. So modifier 22. So it will be reduce or discontinue service. We start the procedure, and we try to save the individual's life. We started the procedure, so we should, we could charge for them. So it has to happen, or something greater happen, and we have to do more. So again, modifier 22, and the proper documentation, it will change the price or the charges for that service. Modifier 52 is for service that be partially reduced, or again, it's not exactly what the CPT code says. 53 is discontinued, so that one is that the whole thing stopped, usually because the patient died, so patient expired, or it become a problem and the patient couldn't do the surgery. Again, you started the whole thing, so that means that you can bill for it, but not bill for the whole thing like if you did it. So modifier 53. Modifier 73, discontinue outpatient procedure prior anesthesia administration. So someone was gonna get surgery, and for whatever reason they canceled it. Patient didn't want to do it, surgeon didn't want to do it, whatever it was. So you did not start the procedure. So you put the patient all the way ready, and no anesthesia, so no procedure. So that usually happens. Some patients can have panic attacks, problems with the heart just before the surgery, and the surgery is discontinued. So You put all the effort into getting them there, but did not happen, did not start it because there was no anesthesia. Modifier 74, well, now we put anesthesia on the patient, and now after a little bit, they could have a reaction, a bad reaction to the anesthesia, and then after that you stop the procedure. So discontinue procedure after anesthesia. So again, it's being specific. You discontinue the procedure before anesthesia, with anesthesia, or right after you put it. Global surgery or global period, global complete procedure. It means that you are going to have what we call a surgical package. So there's a code that takes all of these things, okay, all of them. So you do the anesthesia, the procedure, the follow-up care, and the pre-ops. All of them are under one code, and this is the thing that makes some surgeons crazy. You charge for that CPT code, and it includes the whole thing, the anesthesia, the procedure, normal, follow-up care, and including the pre-op. Now, can you put some modifiers to it? Yes. Okay. So if you put some modifiers to it, well, it's gonna change the prices. For example, modifier 54. I'm only doing the surgery or the surgical care. Okay. That means that someone it's doing a second somebody else that is not the surgeon is going to do the visit for that patient because someone is on vacation. So another doctor will do the other thing. The guy that pay this, like pay the surgical package, is not the same guy that is doing the procedure or the checkups or whatever it is. When that happens, then you can put a modifier and it will get paid differently. 55 post-op care management only. So you go from one doctor, they do the surgery, and then you go to another doctor to check after the fact that other surgeon did not or doctor did not get paid on the first time because he was not the one that did the surgery. Somebody else can do it. Again, it depends on a bunch of things. One of the things is that they are not working under the same MPI on the same tax ID number. 56, pre-op management only. Usually happens when there's a doctor that's going to do the surgery, and another doctor is the one that's going to clear for that surgery. So when that happens, again, you have to do 56 so you can separate the pre-op and the surgery. Modifier 58, it is for stage or related procedure service by the same physician or other qualified healthcare professional during post-operative period. So we do something, we plan to do something, we get ready to do that, but then as we're doing the surgery, something else happens. So we need to make sure to add it. 59, distinct procedure service. So again, kind of the same principle. We're doing something that we already planned for, and in the middle of something else comes, and then we have to do it. We're not gonna check for anything while we're doing the procedure. We don't care about the payment at that point. We do the procedure and then we charge for it. We're saying that we did more, so modifier 59. Now, again, all of those are for evaluation and management. I mean, for surgeries, not for evaluation and management codes. Remember, there's a few CMS codes that we could modifiers code that we have for level 2 HECPEX, and then we're gonna have a different code for the 59. So instead of using 59, we're gonna use this these letter ones. XE, separate encounter. XX is for separate organ or structure. XP for a separate practitioner, and then XU for unusual overlapping service. So that means that if we're gonna use something that looks like modifier 59 in HECPICS level 2, then we can use these ones. Again, I'm going through all of them one by one just so you can hear and know about them. They're gonna be in your book. They're gonna be in an appendix. In the day of the exam, they can ask you any of them, and what you have to go to the appendix and look in the list. They're gonna be in order, and you get exactly what they're asking you for. 63, procedure performed by infants less than 4 kilograms. So same procedure. If the procedure is done in a baby less than 4 kilograms, we're talking about less than 8 pounds, a newborn, a preemie baby probably. It's gonna be a lot more difficult than to do it in a full-grown adult. So modifier 63 usually for more payment because it's more complicated. 78, on-plan return to the operating room procedure by the same day and related to the procedure. So if we send the patient twice to the surgery room for something that happened, usually when something opens, they have to send them back again. Second time, you have to charge again. Modifier 79, unrelated procedure service by the same doctor during the post-op period. So again, anything completely different from what happened before. We already gave you an example of that one. 6 weeks following surgery, the patient underwent diabetic repair of the retinal detachment in the right eye. So we did something in one eye, and then 6 weeks later, before the 90 days, the patient came back and we did something in the right eye now. So again, 79 to say that it's a different procedure in a global period, and RT for right. Modifier 27, multiple outpatient hospital evaluation management encounters in the same date. Again, you should not have multiple evaluation management services on the same day by the same doctor. So let's see. What's an example? Patient was seen at the hospital. We see a level 4 evaluation and management for fractured ankle. The patient was seen the same day in the urgent care, and then a level 3 for migraine that did not respond to medication. So they went to the same place, the same day, and we treated 2 different things: a broken ankle and migraine. So you have to make sure that you have those codes 27 to know that those 2 things were different. We already saw that on the top. Modifier 50, bilateral procedure. So again, same example as before: surgery in one hand, surgery in both hands at the same time, an x-ray in both hands, in order to tell me that the procedure is done twice, bilateral, or the best way is to put modifier 50. If you do not put that, then it will be considered duplicate, and one or both could be denied. So just by adding that 50 after the code, that will let the insurance know that was done in both parts of the body. Now, if not, you could always put an add-on code. Usually an add-on code will say that you did something twice, but that doesn't mean necessarily that you did it bilateral. Bilateral means that you did it in both parts of the body, both eyes, both ears, both arms. But you can do something in the front and in the back of the patient, and that will require an add-on code, not modifier 50. Even though you did it twice, you didn't do it in 2 parts of the body. So modifier 50, think about 2 x-rays, one in one leg, one in the other. Again, same thing. If you have something that you don't have in 2 sides, so you cannot do it. So think about something that happened in the front and back. You don't have 2 sides of it, so you cannot use it modifier 50. Something that happened in the trunk or the arms or the legs, separate, unless it happens in both legs, both arms, you cannot use, at that point you can use modifier 50, if not, you cannot. Modifier 51, multiple procedures. It's reported when multiple procedures other than the evaluation management services are performed at a single patient encounter by the same provider. So multiple things multiple parts of the body, modifier 51. Repeated services or repeat services, modifier 76. It's for repeated services by the same physician or qualified healthcare professional. Example is we did EKGs. So we did an EKG when the patient got in, then we did one 30 minutes later, then we did one before we let the patient go. We need to report codes and modifier 76 in order to know that we did the same thing multiple times. Modifier 77 is the same thing, but now it's a different doctor or a different provider at the same time, the same date. So in the hospital, we did two different procedures by two different doctors. That's okay, but if we do the same procedure, we need to make sure that it's modifier 77 so we can bill properly. Multiple surgeons. This is different from surgical team, different from assistant surgeons. Two surgeons, okay? Two surgeons. We're doing a surgery that we need two individuals, okay? And they are different because they're doing different things. Two surgeons. So if we put modifier 62, we know that we have two surgeons that we're doing two different things at the same time. Perfect. Modifier 66 is a surgical team. So now it's not two, it's a super complicated surgery that has multiple surgeons, multiple individuals, usually three or more. There you go, three or more surgeons, and are gonna be participating in the surgery with their own expertise. So again, super complicated things where we need more than three surgeons. But again, different from assistant surgeon. 80, modifier 80 is for when one physician assists the other one doing the surgery, okay? But they are actually doing, both of them are working together. Modifier 81 is a minimum assistant surgeon. It is when one is there doing the surgery and then something happens that they need a second surgeon for a little bit of time. So again, super minimal assistant, but both of them did something. Modifier 80 will be an assistant surgeon, but there's no resident surgeon available. So that means when you go to the hospital, we have residents in the hospitals helping. The doctors are already finished. So if there's no one there and we need someone, then we could charge for that one because again, the residents already get paid and a salary, so they're not as part of their training. So we cannot charge twice for them. Modified 23, preventive services, example is when a primary care provider provides 20 minutes of smoking and tobacco use cessation counseling. So again, it's extra time, so you need to add that modifier so you can get paid a little bit more. 26, and this is the one that I mentioned. You're gonna see this a lot. Modifier 26 is a professional component. So a surgeon is going to perform surgery at his office, little tiny surgery. They could charge the whole surgery. But if they go to a place and they are going to only perform the service or the surgery and not charge for the instruments and the things and the time of everybody else, then you just put modifier 26. That means that the doctor goes into the hospital, uses all the things that the hospital has to offer, and he just charges for the doing the surgery. The hospital charges for everything else: the anesthesia, the nurses, the room, everything else. Modifier 32, mandated services. So second, third opinion for surgical procedures. An example of that one is a patient primary care provider recommends some specific treatment, and the payer requires a patient to undergo evaluation in order to be seen by the specialist. But usually that happens. The insurance company is going to request things, and when they request them, we call that mandated services. So modifier 32. Because if not, like, why are you performing the same procedure twice? Why are you evaluating the patient twice? Modifier 23 is unusual anesthesia whenever something happens because of the patient's condition. They might need more anesthesia, level anesthesia that is beyond what is supposed to go for that procedure. Then you do it. Usually, one of the examples is local anesthesia for a C-section for a female, but then the female is not no, let's say not cooperating to get the anesthesia. So you have to do general anesthesia in order to do it. And again, it's unusual, so we want to put 23, and then the documentation has to specify why are we doing this? Why are we using that? Modifier 47, anesthesia is by surgeon. So if the surgeon is applying the anesthesia, then modifier 47. If not, then you need to do the CPT code for the anesthesia and the CPT code for the surgery. When we're doing labs, modifier 30 is outside lab. So we're sending the sample to another lab in order for them to do that. So you took the sample, so you're charging for taking the sample, and then the outside lab will charge for performing the actual examination of that sample. Modifier 91 is a repeat clinical diagnosis on lab test. So if we have to repeat a test for whatever reason, confirmation usually, they do it again. So the second time they do it, they put a modifier 91 just to know that we're doing this twice in order to confirm. Modifier 92 is for alternate laboratory platform testing. So if you do example here, it could be any type of testing, but in this case it's HIV test. They do it in the emergency department, and then they use that same kit to test the patient again, and it's in a different lab than 92. And then you've heard about a bunch of modifiers. Like I said, some codes are going to have multiple modifiers. So there's a modifier for the multiple modifiers. And now that one is 99. For whatever reason, this is one of the ones that they like to ask in the exam. So modifier 99, saying that code has multiple modifiers. So you can put up to 4, but then the last one, it could be 99, meaning that it needs more. So it will be added to the next line. This is an example of how it works. So it's where is here? Frank, where is here? There is a storm. Where's the storm? Where are we located? Hialeah. Okay, stay safe. Example, assistant surgeon 80, unusual service 22, bilateral procedure 50, surgeon providing anesthesia 47, hernia repair. So you have to go and say, wait, I have a 99. That means that it has multiple modifiers. And then go to the modifier line and put all of them in block 19. We'll see this when we get to the CMS 1500 form. No problem, no problem. When we're doing UBO4, it's you have multiple modifiers with the same code. So the beauty of it is they can put it in the same line going down. So here I have to say, wait, I have this code and this modifiers. On the next line, I'll put all the modifiers. Here in the UBO4, that's CMS 1500. In the UBO form, I can say 1, 2, 3, 4, 5. Every one is the same procedure, but each one is getting a specific modifier. So I can go down that line and add as many pages as I need. So it's a little bit easier to do in the UBO4 form. So again, if you're planning to end up working at a hospital, this is how you have to deal with them. And then modifiers that clarify specific things. Again, left, right, LT, and RT. Telemedicine modifier 95. Synchronous, that means that it's at the same time. Real-time interactive audio and video conference. And then rehab and ability services modifier 96. Again, patients that are learning usually after a stroke, skills and functioning for daily life, living, or a kid that is learning how to speak when they're not speaking properly. Any of those things are going to be 96, 97. Rehab, again, kind of the same principle. Someone has one-on-one patient contact with therapeutic activities to improve functional performance as a result of a stroke. I know this is a lot. I hope you are still with me. We are moving fast. Okay, I think I will be let me see. See how it is. Give me 1 second. Okay, I will only today we'll finish with evaluation and management, and then tomorrow we start anesthesia and then surgery. Okay. So evaluation and management codes, they go from 99202 all the way to 99499. They are the ones for encounters. They are the ones for evaluating a patient and managing that patient. You can see them in doctor's offices. You can see them in clinics. You can see them in hospitals. You can see it in inpatient. You can see it in outpatient. All of them require levels 1 through 5 of how complicated things are, how much you have to ask, and how much time you spend with the patient. It could be for diagnosis, it could be for treatment, it could be for surgery, but again, to plan the surgery. And they are specific, and they are the ones that you can actually build up. So we already know. I'm gonna write it one more time. 99 is an evaluation management code. CPT codes have 5 numbers. That second number is place of service. Next, the fourth number is type of patient, and then the last one is level of care. So if I say that the patient was sitting at the office, that's a 2. If the patient is a new patient, that's a 0. And level 3 will be 3. So that's how you make up those numbers or build up the code. So sometimes you will be able to learn the things and then follow what you think it is, and then get it by just what it is. Now let's show you how they go and how they work. So again, one of the things that you need to know is that for the evaluation management, we're looking for 3 to 4 things. Number 1, evaluation management, the first 2 codes, and this is how I go again by saying evaluation management or CPT codes. All the CPT codes are 5. That's first 2 numbers are always going to be 99, so that you're good, 99. And then you have to say, well, where is this? So again, next number, it's POS, place of service. Then we can have type of service or type of patients, and then again, level of care. So if you know those things, you should be fine. You should be good. The ones that we get complicated is with some of the wordings, but type of service and place of service are going to be given. So again, they're going to be almost the same ones always. And when it gets complicated, it's to level of care. That's the last one. So level of care depends on what we did, how many questions we asked, what is the history and the examination of that patient, and how complicated the medical decision making it is. If it's super simple and not complicated at all, it will be a lesser level than something that is super complicated. So if you go for a doctor's office for a yearly checkup, it will be a level 2. Everything's okay, I have no conditions, I'm just checking. But if you go for surgery, then it could be a level 4 or 5. If we have to ask a bunch of questions and prepare you for possible surgery. So again, the simplest way to remember this is the highest level of care takes the longest, and the level of care that is the easiest will be shorter time. So level 2 is we'll end up with a 2 for at least the 99 to 02 and 012 and 212, and then 3 will end up in a 3, 4, and a 4, 5, and a 5 for the first few. Now all of them, because when you go to the hospital, it change. But for the first few codes that we have, 99 to 02, 99 to 03, 99 to 4, 99 to 05. That's it. Those are the options. Established new patient, doctor's office, or outpatient facility. Level 2, 3, 4, 5. To established patient, then you'll have 12, 13, 14. So 2, 9. So 99, that one and that one are going to be the same, just one is new, one is established. Simple as that. When you get to the hospital, when you get to some places, most of them are like that. They have a few extra things. So the number one thing that you need to do is identify place of service: hospital, clinic, doctor's office, outpatient, inpatient, and then the type of service provider. If it's a consultation, if it's an admission, if it's an evaluation matched by itself. Then the patient, if it's new, established, or if it's initial subsequent care for like a consultation or someone that is being in the hospital. Then you check the medical record to see the medical decision making or the time. Usually they put the time. Time is better. It goes in increments of like 20 minutes. So 2 will be 20, 3 will be 30, 4 will be 40, and more than 60 will be 5. So that's kind of a easy way of knowing this. Place of service is where? The office, outpatient. So office or outpatient is the same. Another example is in the hospital, but in the emergency department, that's also outpatient. The type of service is what we're going to do: preventive services and preventive medicine. If it's in the hospital, it's critical care or critical services. And then, or it could be inpatient. If you're inpatient, then hospital, inpatient care. Now, when we're doing this, we're gonna be as specific as possible. So when you're doing the specific, you need to know what each level is. So examples for the classifications, 99 to 02. So we're talking about level 2 here, right? Because the ends with a 2, so that's level 2. It's an evaluation and management service reported by the new patient, that's a 0, and requires medically appropriate history and examination. Straightforward decision making usually requires 15 to 29 minutes. That's why I tell you that it's 2, it's 20-ish minutes. In this case, level 1 so 211, evaluation and management service, established patient, and qualified healthcare professional might not be required. So the nurse, the medical assistant did the job. So again, not a lot of questions, not a lot of medical decision making, or it's not hard. It takes less than 10 minutes. That's a 1. So after you look into the things that were what are we doing evaluation and management, what type of care are we doing, and we start to look at the patient, new or established, it's an initial or subsequent visit. And then some services could be separately, history and examination to see how complicated it is. Uh, Again, you decide the level just like that. If it's a new patient, and we already talked about this, a new patient is a patient that has never been seen by the doctor, that specific place, or has a new insurance with that doctor, or it's someone that's been out of the office for more than 3 years, or out of the hospital, out of whatever, more than 3 years without seeing that doctor, you're a new patient. Or if you have a new insurance company, you are a new patient to that insurance company. Or you've never seen a doctor, or anyone that is in the same MPI as that doctor. Like, if you go to your doctor's office and then a new doctor is there, if they are under the same practice, that is the same doctor. So that's new patient. Established patient is someone that has been there before. Okay, it's someone that been taking care or has been asking for care in that same facility, same doctor, same thing, and it has not passed more than 3 years since the last visit. So it's a new patient the first time, and it's established patient anything after that. Examples here, this guy came here March 15, 2019, then he came back in January 1st, and then December 1st. There's no more than 3 years passing between visits, so that patient is established patient. The first time, it was a new patient. And again, this is a patient that was seen by two different doctors with two different MPI numbers. Now, initial and subsequent services. When we get to the hospital for inpatient, instead of saying that the first visit is a new patient visit and the second visit is an established visit, if you're in the same admission, so the first day you have an initial visit, the second day you have a subsequent visit. Okay, the third day you have a subsequent visit. If you get discharged and go to your house, and then a couple of days later you end up in the hospital again, that time that you get to the hospital, it is again an initial visit that first day and subsequent visits after. Anything else that happens during those visits that is not observation of the patient by the doctor, is going to be reported separately. If they do a test separately, if they do an EKG, X-ray, whatever it is, sonogram, all of it is going to be reported separately. So the way that I like to describe it is like when you go to a hotel, you go for a hotel and you pay for the room, and if you ask for room service, that's going to be extra. Kind of the same principle. Anything that you get extra will be reported and it will be billed separately. We could have something that is called concurrent care, transfer of care, or counseling. Concurrent care is everything that you can imagine you get in a doctor's office visit. More than one doctor, they check everything that's happening. Everything happens on the same day. That's concurrent care. The admissions doctor, the ER doctor, the admissions doctor, and then a specialist that comes to visit. All of that will be concurrent care. Transfer of care will be when someone that is managing that patient sends the patient to another patient, another provider. Usually, ER to admission is an example of transfer of care. And then counseling is when the doctor is talking to the patient or the family member, talking about results, impressions, recommendations, maybe surgery, benefits, treatment. So that is counseling. Counseling is different from to observational care. So usually counseling will be done by a specialist, and then the hospitalist, the doctor in the hospital, is the one that's taking care of the admission and discharge. So let's talk about this section here, that it's the levels of care. As simple as I can make it, the more difficult the medical decision making is, the higher the level. The more time you have with the patient, the higher the level. If a medical decision making is hard, it will take more time. Or if you took more time, it's because the medical decision making was hard. So that will bump up the level of care. So how many things are we checking? And how complex are the problems? So the patient is a diabetic, has a heart condition, broke his leg, and wants to commit suicide. There's a bunch of problems. There's a bunch of them in number, and they're complex. Now, what do I have to do? Do I have to check your heart? I have to check your leg. I have to do this. I have to maybe I have to do surgery. So the more complicated it is, the more risk, the more the higher the level of care. If I have to look at labs, different results, um, imaging, all of those things, so I have to review more documents from other facilities. That makes it more complicated. So we do 4 examples. The medical decision making will be straightforward, or the complexity of the medical decision making will be straightforward. Simple. You're here for a follow-up. There's nothing wrong. You're good. Okay, straightforward. Now, if you have 1 or 2 conditions and it's not super complicated, it's just to treat 1. That's a low. Moderate. When we talk about moderate, we're talking about a few conditions that require multiple organs and multiple things. Or high, when we have many conditions, many things affecting the patient. So again, the easiest way to do this is time. Remember, 20, 30, 40, and then 50 to 60. So we're talking about 20 is level 2. We're talking about so let's talk level 1 is when the doctor is not present. It's just the medical assistant or the nurse that does the evaluation, like blood pressure or reading a result or whatever it is, PPDs, examples like that. A nurse could do it. So um, level 2, 20 minutes. Level 3, 30 minutes. 40 minutes for 4, and 5, 60. So if you come in and you have diabetes and everything is good, then the doctor will probably do a 3. They have to check diabetes, check your results, um, check your medication, stuff like that. If you have a diabetes, heart condition, and I don't know, high blood pressure, then we have to check the cardiologist notes. We have to check all the medications that you're taking. We have to check all the systems. That's probably a 4. And then a 5 will be all those things plus we're gonna do surgery to fix some of those problems. Then it becomes a long, complicated medical decision making that has to be matched with all that documentation. So I need to prove that I check all those things. I need to prove that I saw all those results and that I act upon them. So face-to-face time, it's kind of a tricky one. It's not specifically has to be specific, like 15, 20 minutes, whatever it is. It means that the time that you went with the doctor or the patient and the family member, plus the non-face-to-face time is the one that you did not spend with them, but you were checking things, getting ready to see the patient, getting their medical records. Is called as non-face-to-face time. So you have both. So face-to-face time, again, is the amount of time the patient and the provider spend in a room, okay, with the family. And usually when you think about you as a patient, you're like, well, I went in, the doctor came in really fast and never come back. So that's not what we're talking about. You don't need to be 60 minutes with the doctor face-to-face. It's a combination of face-to-face and the non-face-to-face. And let's go to the next. We're almost done here. So, evaluation management. You're going to be in the office or outpatient services. They could be the hospital as an inpatient. So both of them, okay? In the office, it's provided by in a physician's office or any place that it's outpatient. It could be a hospital. They're gonna be history and examination. It has to be documented. The total times face-to-face and the non-face-to-face have to match the documentation. The place has to be in the doctor's office, or it has to be documented where it is. The time, again, is based on the level of history, examination, and medical decision making. The more of those things we have, the higher the level. And the last thing, it has to be established if the patient is a new patient or an established patient. The only one that is not included in the time is the one, and this is 99211. So that means there's an evaluation and management code in a doctor's office for an established patient that is not seen by the doctor. So it's called a nurse visit. I know the same thing, but it doesn't go, nothing happens with the, at least there's no face-to-face with the doctor. Again, documentation is required for all of it. Now, there's a fancy word here. It's called undercoding. Okay, so if you wanna try to do that, so reporting a code as a lesser value than what it is, just to have less documentation or less things and just get it paid, that's undercoding. It's the opposite of upcoding, that is going to the higher level. Both of them are wrong. Both of them are illegal. You have to be careful if you end up at a place that they like to do that. So if I need a lot of documentation to get a level 2, I might not require a lot of documentation. Let me just charge a level 1 and be done with it. No, that's wrong. Or the opposite. It was a level 1, and then you go like, let me charge a level 2. Again, if it didn't happen, it's you're lying about it. It's illegal. You should not do those things. In the hospital, it's a little bit more complicated. In the hospital, you're gonna be an initial every time that you go to the hospital and get admitted. That first day is admission. It's initial observation. Anything after that is going to be subsequent. So the first one is initial. The next one is subsequent. It could be observation care between admission and discharge, or anyone that is under observation for one day only. Again, it has to be at least 24 hours. So usually the observation happens when someone is like in a surgery or something, but it doesn't have to be more than 24 hours. Hospital inpatient or observation discharge could include also the final examination and the discharge and instructions to go home. For a hospital stay, you have the LOS, that's the length of stay, and then any observation services will have bed for a specific amount of time. You should have a nurse or a staff taking care of you. Not necessarily have to be in a specific place, but it could be an observation area, or it could be in the inpatient. Medicare requires physician to order an inpatient admission for the duration of observation care to be 48 hours or more. So if you are in observation, it's 2 days. So again, after 24 hours, the next hour after 24 hours is going to be considered the second day. So you're going to be 48 hours. But in many other providers will be okay with 24 hours. So 24 hours already admission. In Medicare, it's 24 plus. So that takes it to 48. Partial hospitalization or short-term intensive treatment program where individuals are experiencing an acute episode. Usually when they psychiatric hospitals, stuff like that. So again, it's a kind of a 24-hour inpatient, or at least, you know, going in and out of the hospital. A consultation is when a specialist comes in to check or look into something with that patient that's going to be charged as consultation. So it could be an inpatient consultation or it could be an office outpatient consultation. So if you have a specialist in the clinic and you call that individual to do a consult with the patient in the same clinic, that's an outpatient consultation. If you are admitted or the patient is admitted and then you send someone to do the consultation, then there's going to be an inpatient consultations. I like this. It says don't confuse it with referral. If I send you to a different office that is a referral, it has to be the doctor goes to the same day, the same place that you are to be a consultation. So the patient doesn't move, the doctor moves. If you move the patient, then that's a referral. For the emergency department, emergency is anything that is provided at a hospital. It's 24 hours. Just, you know. Now, when you go to the ER, you could be new or established. So just because you went to the hospital for admission, that doesn't make you new or established patient. When you go to the ER, you could be new or established. The first time you go is new. Second time you go or subsequent visits, you're going to be established. So it's a little bit different than on the inpatient, because inpatient you're going to be initial and then subsequent. Here you're going to be new or established, just like any other outpatient facility, just like the doctor's office. Same things. 3 years without going to that hospital, that ER, you are considered a new patient again. Even though if every time you go you have something different, it doesn't really matter. Critical care service, delivery medical care by physician or patient who's critical, ill, or injured, is a little bit different from the observation in a hospital, because it requires more things. So because it requires more things, it's going to be more complicated. It's going to be more expensive. So you need to make sure that every single thing that is there is documented and covered, because you're going to pay a lot more. And the times are a little bit more specific. You can send the patient to a nursing facility for care, and then they're going to be admitted. So initial, subsequent, discharge, and all those services are going to be included, just like if they were in an inpatient hospital. So usually these are lesser institutions compared to a hospital, but just because that's the case, they're going to pay a little bit less. So it's better if you send them there. It could be a home or resident services. Again, they are outpatient services, so they're not in the hospital, they're not admission. So new or established patients, and then again, simple as before. All of them are outpatient. Prolonged services, in this one, so you are going to have patients that go in and out to the facility. So because they're going to be in and out, they could be outpatient. If they're going to stay, they can become inpatient. It depends on the facility. So if they can be there and go, it's more evaluation and management. And the difference is when the individuals there compared to when they're not. So case management services, we talk about case management already in the different type of insurances that we have. We have a workers' compensation, where we have case for whatever happened. and an individual is going to be responsible for the coordination and controlling the access and everything that have to do with the healthcare of that individual. Yeah, care plan oversight services and preventive care, preventive medicine. There's again, it's a little bit different, but they are just checking that everything that we're doing in hospice care, nursing facilities, uh, it's a way of controlling risk. Uh, and then the way that we do it is by having more preventive care visits. Again, all of them are going to be outpatients, so that's why we have the new and established patients. We are not having individuals in preventive care services being admitted. So admission will define the purpose of being prevented. So again, many different ways, and all of them are going to be evaluation and management, and all of them are going to be outpatient. Non-face-to-face, telephone services, online digital evaluations with camera, without camera, stuff like that. All of them are gonna is kind of a new thing. Again, they're not new. We had them for a long time. COVID kind of expedited the, the use of them, and now it's a little bit better. You can have patient to doctor. You can have multiple professionals in the call, whatever it is. So everything is payable now. Before it was really hard to pay. Now, because we use it a lot, and this has changed since COVID, those non-face-to-face services are being paid as good as the face-to-face ones. So there's a lot more, lenient with those things, and easier for providers to get them paid. So providers are doing them more and more. Again, patients don't have to go to the office. It's a lot faster. You know, uh, more time for for patients. Patient evaluation and management services, again, super simple. These are the people that are going to certify for disability or disability insurance, or anything that has to do with that. So if anyone has a problem, you can go to one of those professionals, and they're going to do the evaluation that way. So it's a little bit different than doctor's office. It's more, it looks like a social workers kind of thing. But again, it's an outpatient, and it's part of evaluation and management. And then different parts of life, newborn care services. Again, they're going to be in the hospital, birthing center, or home birth. And then again, any of those things are going to be uh, outpatient if they're not in the hospital. And then the process will be delivered by evaluation and management. Again, not the actual delivery of the baby, but then the evaluation management of it. If it ends up being anything that the baby uh, delivered the baby and they have to do resuscitation, and also it's going to be included here, even though that's not the provision why they made it for. This is delivery, birthing room attendance, and resuscitation services. These are the ones that I'm going to use for the baby. Again, you need to understand that at that point the baby is not alive yet, so it's outpatient still until it passes a specific amount of time. Baby is born, and now we have inpatient neonatal intensive care services or pediatric or anything that has to do with critical care services for the baby. At that point, the baby was born at the hospital or got to the hospital in whatever conditions. They're gonna be it's gonna be an inpatient all time. Following the assessment for individuals that are have signs or symptoms of cognitive impairment. Again, they could be outpatient or inpatient. Care management services like before, but now for individuals that are doing the managed care at home, psychiatric collaboration care management services, or again anyone that has the problems with psychiatric problems for interventions. Again, same thing. We do the services could be in a facility, or it could be in a walk-in basis. It depends on what it is. So this could be inpatient or outpatient. transitional care management services. Providers are or the services provided to medical or psychosocial problems, usually people that are in uh, like safe houses and stuff like that. Again, they can have acute care in the hospital or in the community setting or home, for example. Again, inpatient if they get to the hospital, or outpatient if it's in the community setting. Advanced care planning, it's face-to-face, physician qualified, and it's counseling for durable medical equipment, attorney. So this is the social part of the care, social workers, while the individuals in the hospital. That visit could be outpatient, or it could be while the patient is admitted, and then this is with the family members, and then it will be evaluation and management in inpatient setting. Behavioral health integration care. This is for the face-to-face, and it's more for treatment and for substance abuse. So if the individual is again admitted, you can do this in inpatient. Usually is outpatient, and we have specific localities that do this. And just in case we haven't covered like 300 million things, we have other evaluation and management services. The code that we're going to use is the last one, the 99499. When we are doing a type of evaluation and management that is not any of this 300 that we just mentioned. So if the code is not there for whatever reason, then we can always use this. The room for expansion here is limitless because it's anything that fits here. So we don't have to add numbers and codes to this. We just use this one whenever that thing is not there. That's going to happen with many of the CPD codes when we get to a point that we use all of them. So we have usually take the last one, and then we just say other. Whatever we don't know, then it goes from there. Same thing. This is for you guys to do homework. Yes, we got to the anesthesia part. I'm gonna stop here. So we are gonna on Thursday we're gonna continue this. This next two sections are the kind of the biggest ones, and they go together. So anesthesia and surgery. It takes a while to go over everything, so I will try to get the other PowerPoint to do it a little bit shorter. But yeah, that's kind of what we're doing here. This is the part that gets, long and tedious, but you have to see all these things. You have to at least remember that they exist. So whenever we go over them in the book, at least you have a reference to go by. See, let me start the chair here. Who do we have here? Who do we don't have here? Let me see who I do not have here. Are you still here? Are we good? Simple. I'm gonna start calling names, and you're not here or you're not here. Let's do that. Wrong class. People, are you alive? No one. Oh, I'm sorry. I'm so sorry. You're answering. I didn't see it. Oh, sorry. Everyone's saying yes. I'm sorry, people. I don't know when it was here. Okay. Hi. Good. Thank you for being. Yes, it is a lot of information. I know. Okay, let's see who is not here. I think it's easier. parser here? I install parser. Yes. Yes. Okay, people. I think that's all of you. Any questions? Anything before I let you guys go? Oh, I don't like this. When I have this, I cannot see your. Why I cannot see this when I have these? Okay. Yeah, that's okay. So okay, cool. I will see you guys on Thursday.